Testing 1, 2.
Name and claimant, sir? Yep. Yeah. My wife's grandmother told me, like, she was a doctor. He's like, man, you have emphysema. She said, I got 50, but I don't. I'm like, well, you got, I mean, the test says you got it. So I'm going to go. It's like, well, I mean,
Test 1, 2. Test.
Trying to bring somebody in here. Here's the problem. Before we were live streaming, I had a couple of people that could do it. I could just take off. But now I don't. Got one person that kind of can do it. I'm trying to train somebody else to do it. So it's
cool. I'm good. All right. Hello, everyone. We're going to go ahead and get started. I'm Dr. Hurd. I'm one of the rehab attendings on the 7th floor. So they asked me to, hey, rehab team, to go over like all the admission criteria to rehab to help you guys get your patients up to us sooner, quicker, faster. So that helps everyone. I'm going to do the first half. Kelly, our admissions coordinator, is going to do the second half. So these are our objectives. We're going to talk about how to identify the patients to meet criteria for rehab admission. Also identify any factors preventing their rehab admission, describe the role of a referral, and to discuss the differences between SNF and inpatient rehab. There's a big misconception about SNFs out there. They're good. Rehab's also really good. Disclosures, we have none. So in order to come to rehab, we have to meet some certain criteria. We need to check some boxes in order to get the patients up there. And these are it. So the first place we kind of start is the diagnosis. Medicare has defined 13 roughly diagnoses that have to be actively treated in an ongoing care as a part of their current hospitalization and acute care. Even if they've had old injuries, strokes, whatever, in order to come to rehab, we focus primarily on the admission that brought them into their active hospitalization. So a good example is strokes. A lot of patients have had old acute strokes and come in for pneumonias and things like that. Even though they have had a previous history of strokes, that doesn't really get you in the door. You would need to get in under a new different rehab diagnosis. Another one Kelly wanted me to point out was hip fractures. This has to be a fracture of the actual hip joint. Can't be a distal femur, can't be pelvic fractures. It could qualify under maybe a different diagnosis like a polytrauma, which involves multiple fractures and multiple joints. And the other thing she wanted me to highlight was brain injury. This can be both traumatic and non-traumatic brain injury. So little ladies that get, the metabolic encephalopathies because they have like some pre-renal azotemia, we can get that in. And these are some more severe osteoarthritis. Really have to that's one's really difficult to get in because you got to really diagnose it's a big flare in their arthritis that causes loss of their range of motion and a steep functional decline as a part of that with muscle atrophy. I've actually never seen that get admitted in all my years. Otherwise, active rheumatoid arthritis, we can get that in, and some systemic vasculitis. So this is a big one. We get this a lot from ortho. We get a lot of ortho patients up there for single joint replacements. Hip joint, elective knee for non-fracture origin replacement does not in and of itself meet criteria unless you have an elective bilateral knee at the same time or elective bilateral hip at the same time. If you don't have that, then you have to have a BMI of at least 50 or an age of 85 or older in order to qualify for a single joint. But if they have had bilateral, it's great. We can admit that. So for the guys that have had single joint replacements, the way we get them in the door is that we have to define a certain level of medical complexity in order to justify having the patient admitted, because part of the admission criteria is that they're going to be followed daily by at least a rehab provider, and we get usually hospitalist consults on pretty much all of our patients to help with these medical comorbidities. And this is a good list to reference. They have to have heart failure, active MI, that's already been treated. Don't come to rehab with an active MI. COPD, obstructive sleep apnea is a big one, which is being diagnosed more. A lot of people have CPAP machines. That also helps build up the level of medical complexity in order to justify having a rehab provider see them every day, because that is also part of it. In the long time ago when rehabs first got, before I was even born, they would admit hips, knees. There'd be whole hospitals full of hips, single knees, and it's just a way to cut down on those admissions who weren't medically complex enough where it wasn't really necessary that a medical provider see them and follow them every day. So those guys without the active rehab diagnosis, then they would fall in the category debility. And really, you can almost get anything in, but it basically boils down to a rehab admission under debility. And these are basically a very similar list to our previous list. These are little people that have the CHF exacerbations, the heart attacks, the COPD exacerbations, pneumonias, you have prolonged hospitalization, whether ICU or not, renal failure, end-stage renal disease, and they have to be admitted for that. But then the key is that they have some functional decline from their previous level of functional, ideally independence, with a clear goal of transitioning back to a functional level of independence. And this is what we say when we say it has to be reasonable and necessary. They have a reasonable diagnosis, there's a reasonable expectation for them to improve. So the next level is, after you establish a diagnosis, is establishing that they actually need your acute services. They have to need physical therapy. They have to need occupational therapy. And when you see the therapist grade out their functional capacities, they use these things called FIM scores, and they are graded everywhere from independence, completely independence, which is where you can do it all on your own, no assisted devices, no nothing, to total assistance or dependent care where the therapist is doing 100% of the care. And there's lots of gradations in the middle of that. Anyway, it gets down to min assist, which is kind of that and higher. Min assist, mod, max, total, dependent. All those are different gradations of how much care the patient needs in order to qualify. So they have to have those min assist or functionally worse levels, FIM scores, in order to be able to come. Speech therapy is always awesome. We love our speech therapists. They help out a lot with cognition. They help a lot with dysphagia, swallowing, and other things that we love them. But it's not total part of the required thing. You don't have to need speech therapy to come. But you have to need PT and you have to need OT. Another thing you have to be able to do is you have to be medically stable. And you also have to be able to tolerate and benefit from 3 hours of therapy. The level of 3 hours of therapy, which they get daily, they have to be able to do. They have to go to therapy. So if a patient's on the acute care floor and is refusing therapy left and right, those guys that come up there and they may be refusing a 30-minute session, and we're asking them to come up there and do 3 hours a day, and they start refusing, we can't justify their admission. We have to discharge them. So those people are not the best rehab admissions. We like to see consistent therapy where they can not only want to go, they actively participate, and they're able, to tolerate all 3 hours. And that's kind of a judgment call. There's nothing that can swing you, tests, the lab, or imaging that can swing you one way or the other with their ability to tolerate it. Next thing on here we've highlighted is our vital signs that have to be, we have to have our patients so stable, otherwise therapists will not work with the patient. And we can't just have patients come up to the rehab unit, sit for 5 days and not get any therapy, because that's not why they're there. So in order to be admitted, we look at the vital signs very closely. They can have, these numbers are by the American Physical Therapy Association and Occupational Therapy Association have defined these, and it's hospital policy, so that's what we go by, that's what our therapists go by. So the patient's vitals are falling out of these ranges. The therapists are not going to work with them, and again, they should not be admitted. And a good rule of thumb when looking at the vital signs is if you think the patient is dischargeable home or not. If you don't think the patient is stable enough to be discharged home, they're unlikely to be stable enough to be admitted to rehab. We're asking them to participate so much in therapy, out of bed activities, some of the therapists do some weightlifting exercises, some things that really generate a lot of aerobic activity. And if they already have a resting heart rate of 120 and we're like, all right, let's get out of bed and walk 200 feet, and they go up to 150, 160, that's no good for anybody. This is another thing we wanted to highlight. Dr. Middlebrooks helped out with this policy. Patients with a recent history of C. diff, they must have completed 10 to 14 days of antibiotic therapy, documented formed stools, and transfers must be approved by Dr. Middlebrooks and Infection Prevention Department. So another thing that can prevent you from admitting the patients are planned procedures that need to be done on the acute care service. It's really important that they get done there, just the way the payment system is with our rehab. It's a bundle payment, and so when you are sending somebody to rehab, it's a completely separate fin number, and so it's a completely separate admission and discharge from acute care. Even though it can be within the same building, you look at it as a completely separate entity altogether. Just pretend it's across town, it's in Auburn, it's in Chicago. It has to be a discharge and a readmission. So these planned procedures, again, would come out of our bundle payment, so we don't like them to be done on the rehab unit, and they're good ways to, there are areas where rehab admissions can be prevented or stalled just until the peg placement is placed, until any ongoing amputation will be completed, and the patient will be stabilized after that. Plus, if they're getting something major like a new amputation or amputation revision, they're going to have some, they're going to need more intensive medical oversight, and getting them up and moving is not always appropriate. So it's always good to have all those items done. And we can't help the unplanned surgeries and interventions that need to be happened. Those happen, and we have unexpected transfers and discharges back to acute care for things that we didn't foresee coming. We admit a lot of stroke patients on a very modified diet, with honey thick liquids, and they just aren't able to maintain their hydration. And so sadly, with our therapist, our speech therapist can't make them be able to tolerate that liquid enough, and they have to get a peg tube at that time, which happens. But again, if we think in acute care that they're not going to be able to get there and maintain their hydration, maintain their nutrition, then a peg tube placement would be appropriate on the acute care. So this is another thing. Surgeries and acute care transfers require full discharge from inpatient. This is what I was talking about before. You have to look at them as completely separate, distinct entities in of themselves. So patients that have to be discharged to acute have to be discharged after 8 p.m. To acute. So that prevents them from having a documented stay under their day of stay, under their length of stay for the acute care side. Blah, blah, blah. So again, this highlights that if they cannot participate or tolerate 3 hours, then they cannot remain in rehab if they need some acute surgery or acute intervention. So the following are, again, conditions where we cannot accept them to rehab. So if they have chest tubes, rectal tubes, heparin drips, vents, and IV pain medicine, restraints and uncontained MRSA infections and fistulas. It's really important to kind of get those things. Again, all these things points to a more medically unstable patient. So the patients that have chest tubes in are probably not like that medically stable. The patients on heparin drips need to get off those and get on some type of long-term anticoagulation if that's indicated. And then pain medicine, again, if their pain is so out of control that it requires IV pain medicine and not orals, then again, it doesn't, asking that patient to get up and move around for 3 hours is not, they're going to refuse. And then if they refuse for so many days, it's also important to know we actually have to discharge them either to the home, back to the acute care service, which isn't good for anybody in that situation. So transitioning them to oral pain medications helps a lot and get them to us sooner. So I've talked about this also. They require this medical supervision, which is coordinated by a physician and the medical team with nurses, with their assistants as well. We're open to consults. We just ordered an inpatient rehab facility consult, and either Bethany, who's our nurse practitioner, will come to the patient, evaluate the patient, or Kelly, and they usually run it by me, and we usually talk about it at great detail, because a lot of documentation has to go into that, either admission, or if we're end up not admitting the patients, working with the acute care team and establishing a reasonable plan for admission, or our reasons that we would ultimately decide that the patient's not appropriate for acute inpatient rehab. So when we admit somebody, they have the diagnosis, they have the FIM scores, they have the medical complexity. The other thing that we have to actually justify and think about is that the patient has a expected ability to improve functionally within a certain reasonable amount of time. So Medicare has generated average length of stays for all their diagnoses. Stays in rehab, if you can tell your patients that's for a minimum of 1 week. I tell everyone that on admission, but we take it every week. We have a team conference. We had one today actually, where we discuss all their FIM scores, their progress over the previous week, and when we think that they can discharge home. Just because you're admitted does not mean you're guaranteed any length of time. Even with private insurance, they usually approve it for a week, 10 days at a time, and where we have to resubmit FIM scores that document their improvements to justify, again, continued stay. So it's not always, basically you have a week usually guaranteed, usually. And then Kelly will talk about this later. And the same with when you discharge somebody to a skilled nursing facility. A 21 guaranteed stay is only available at the skilled nursing facility. But rehab in and of itself does not guarantee 21-day stay. So this is a good example of estimated length of stays. For a lower extremity fracture or hip fracture, 10 to 14 days, somewhere in there. Strokes, average length of time is like more on the closer to the 13, 14-day spectrum with most of them. Same with the single joint replacements. Again, those are single knees, really. You have to justify a lot for them to come, just because there's such a reasonable expectation that they will improve in a very short amount of time, where they really stay for a very short amount of time. Amputations, this is good to know for all the vascular surgeons in the room. Usually there's a pre-prosthetic training period where we bring the patient up for 7 to 10 days. We get them functional without the prosthetic limb. They go back into the community, get a prosthetic limb, and they can come back in to rehab from home to be trained to use that prosthetic limb. And so that's something good to know. So that's why that is more probably 14 days. It's probably like 7 for pre-prosthetic, 7 to 10 for post-prosthetic training. And this is where I turn it over to Kelly.
This is your
Okay.
Just pop that one in your other pocket. Let me turn this one on. All right, you're good to go.
Thanks. All right, so once we've determined that a patient meets criteria to come to inpatient rehab from the medical functional standpoint, the next thing that we're going to look at is a safe discharge plan. And this is really where, as a clinical liaison, this is where I come into play. The appropriate amount of projected supervision, that what we're expecting patients to do on discharge from rehab, We use a lot of the notes from the acute care, physical therapy, occupational therapy. They're setting long-term goals based on a patient's diagnosis and current level of function and their prior level of function. So I oftentimes will use those long-term goals in addition to my experience as an OT to determine about what we expect a patient will do at discharge. So we'll take that level. Let's just say we have someone who's had a pretty severe stroke and they're requiring the assistance of 2 therapists to get in and out of bed and on and off the toilet. Well, we know from our estimated length of stay that we're going to have 2 to 3 weeks with that patient. And then they're going to go home with their elderly wife who has a bad back and can't do any lifting. Now, as a therapist, I can see that in 3 weeks I can't get this, our therapists, as wonderful as they are, likely will not be able to get this patient to the point that they can get on and off the toilet safely without any lifting assistance. So I have to look at the amount of assistance that's available at home prior to them coming to inpatient rehab. So we're discharge planning our rehab patients before they ever admit to make sure that once they finish our rehab program, they have a safe place to go. We also need to make sure that we can assess needed services, including outpatient therapy, DME, and a primary care follow-up. Now this comes into play particularly with our indigent patients and some of our outlying insurance companies who don't provide very many services at discharge. So we need to make sure that we can discharge them safely with the needed resources. And so I share an office with Misha Wester, our case manager, so oftentimes we will discuss a difficult patient prior to bringing them in to make sure that we can meet those needs. For Medicaid patients, we like to order their DME, their equipment, before they come up on the floor. So we can make sure that they can get approved through Medicaid before they discharge from our rehab facility. And we have to make sure that our patients are not going to be at risk for self-harm. And so this has come into play, particularly in the last couple of years, as IV drug use admissions and some of the functional fallout from that IV drug use. We get a lot of referrals for patients who are going to be on IV antibiotics at home, but they have a history of IV drug use, and so that's not a safe discharge. And then they would end up staying with us on rehab until they complete their IV antibiotics. All right, we also have to determine that there's a reasonable probability that they will return to community living. This includes the patient's home, a family member's home, or assisted living. If the patient or family plans for short-term or long-term skilled nursing facility placement, inpatient rehab is not indicated. And this is a Medicare guideline as well as an insurance standard. If, as I'm talking with patients and their family members, if they say, let's try rehab, and if it doesn't work, then we'll do skilled nursing after that. That's an automatic, no, we can't do that. And oftentimes then they'll say, well, then we never had this conversation. They try to kind of take that back. But we have to take that into consideration, because if we discharge our patients to skilled nursing facilities regularly, then we get a spotlight from Medicare, and it affects our reimbursement and our ability to provide good care to our patients. So we have to make sure it's going to be community. Now, if someone is planning to go to an assisted living facility, I like to get an idea of which facilities the family's looking at, and I'll call that facility and find out what their requirements are for admission, whether they provide assistance or not. Then collaborate with the therapist, and if we feel that the patient can meet criteria to admit to that assisted living facility, that's a good safe discharge plan. All right, so once we've determined that a patient meets medically, functionally, and has a safe discharge plan, then we're going to contact the insurance company, and this is a huge part of my job as a liaison, as well as some of your external liaisons who are here in the hospital. For insurance authorization, we send all of the clinical information. This includes a good history and physical. It will include any imaging and labs that help to justify a rehab stay, a recent PT, OT, and speech therapy note, as well as the pre-admission screen that I complete. Generally, insurance authorization will take anywhere from 24 to 48 hours. Some of the outlying insurance companies that we use, some of our patients have, sometimes can take up to a week. So just be prepared for that long wait. But we try to get it in as soon as possible. However, we don't want to ask for authorization too early, because those are only good for a couple of days. So if we ask too early and then we have to resubmit because the patient wasn't quite ready to discharge, then that really slows the process down. In fact, Viva has recently changed their standards. We need a discharge order on the chart before they'll consider authorizing for inpatient rehab. Also, therapy notes need to be current within the last 24 hours or so. We have just a little bit of wiggle room with that depending on the insurance company. But that's one reason that we like to get PT and OT started early, as soon as possible. If you can order that PT and OT as soon as it's clinically indicated, not only does that benefit the patient because they're already getting some intensive therapies by our acute care therapist, but also we have good notes. And so as soon as you're ready to discharge your patients to inpatient rehab or a skilled nursing facility for that matter, those notes are readily available and the process moves a little bit faster, a little bit smoother. If multiple facilities are submitting to the same insurance company for the same patient at the same time, it causes a logjam, and they have to stop the authorization process and investigate who is the first choice. So as case management, if you would please indicate first choice on your referrals so that we don't have multiple facilities submitting at the same time. It just cuts down on some of the confusion. If insurance denies inpatient rehab, a peer-to-peer review may reverse the decision. And so generally I will get peer-to-peer information from the insurance company. You as a physician can call on behalf of your patient and advocate for inpatient rehab. We've had a couple that have been overturned by some of the physicians here, and it really works well for the patient. Usually we can also have a patient can also call and appeal the decision as well. It doesn't always work, but if you really believe that your patient needs inpatient rehab, it's definitely worth a try. All right, a word about charity patients in rehab. Charity patients are considered on a case-by-case basis, but in general, they must have a compliant rehab diagnosis. So we're going back to that list of 13 approved diagnoses that we have from Medicare. They must meet all the other guidelines, and particularly a safe discharge plan. If we have someone who is previously homeless or previously non-compliant with their care, that's going to be a red flag for us because we're not going to have anywhere for them to go once they finish inpatient rehab. They must complete a financial assistance application with the business office because while I can look at the medical and the discharge plan side of things, the business office ultimately gets to decide whether or not we can accept that patient as a charity rehab. And we can only have 2 charity rehab patients at a time. Now the good thing about this is we do have low length of stays. We are keeping people 1 to 2 weeks. So if your patient can hang on just a little bit, oftentimes we can make a space for them. All right, if you hear that your patient has been denied inpatient rehab because we are not meeting our 60% rule, I wanted to explain that just a little bit. In order for us as a unit, as a rehab hospital to qualify for PPS reimbursement, we have to maintain 60% of our caseload with those 13 rehab diagnoses. So as I'm looking at your debility patients, I have to calculate how many patients we've had that month that have already been debility. So once we cross that 60%, once I've already taken a high number of debility patients in a month, I can no longer take any more debility patients. So, and we generally, as a rehab unit, we run anywhere between 60 and about 68. So we do, I think, give a fair share of our rehab beds over to debility patients because, as a therapist, I think everyone can benefit from therapy. And so I'm yes until I have a reason to say no. And if we can't accept a patient because of our 60% rule, we only have 16 beds, so it doesn't take us long to get to 60%. If we can't accept a patient, it's definitely appropriate to make that referral to some of the larger rehab hospitals in the area if the patient agrees. And we have some good working relationships with some of the other rehab hospitals and some of the liaisons, and we can definitely communicate and share information with the patient's approval so that we can get those debility patients the rehab that they need. All right, in order to make a referral to an inpatient rehab program, you're going to go through a rehab liaison. Of course, I do that here at St. Vincent's East. I receive referrals through both IRF consult orders that the physicians put in and through EnzoCare. And so as case management, they send out to other hospitals through the EnzoCare system. Once a rehab liaison receives a referral, they're generally processed within a couple of hours, just depending on the load that we have, but sometimes it can take up to 24 hours for hospital policy, we usually have some kind of an answer within 24 hours. And once the pre-admission screen's been completed, we will have that, it's in Cerner in one chart. So I don't know how well you can see this, but depending on how you filter your view, I wanted to let you know where to find those decisions about inpatient rehab. If you'll go to the notes section in your one chart and choose Power Form and then Rehab Subscription, my pre-admission screen is typically the earliest dated document. You're going to scroll down to the very bottom of that document and you'll see a pre-admission review section where we'll give the rationale for approval or denial. And I've also started trying to put in a quick note just in the patient's acute care fin side so that the communication lines are pretty clear about why a patient was either accepted or denied to inpatient rehab. And oftentimes a no is not a no forever, it's just a no for right now. We get some referrals for patients who are very sick and aren't quite ready to come to rehab yet. So if we review it once and it's a no, and your patient's still in the hospital a week later, and you still feel like inpatient rehab is the best choice for them, by all means, definitely send it. And if your patient, you're not sure if they meet criteria for inpatient rehab, I'm always happy to look at it. It's probably, we can kind of look at all the diagnoses, all the reasons that they might need to come to rehab, and we can definitely take a look at that. All right, to improve the rehab referral experience, and again, this is just trying to make sure that we're getting inpatient rehab for all of the patients that need it. Make sure that they receive their PT and their OT early in the process. Write an IRF consult order so we can get our nurse practitioner or one of our physicians in to assess the patient for the medical necessity part. Transition patients from IV to oral pain meds. They need to be off their IV pain meds for at least 24 hours prior to admission. Don't promise a 21-day rehab stay because that causes confusion once they get up to our rehab floor. I just yesterday had a discussion with someone who I felt we were very clear about their short stay, and they began to argue that nope, we get a 21-day stay. So it happens, I would say at least twice a week. We have a conversation with one of our patients that wants to argue for a 21-day stay. And then we want to educate our families that it's either inpatient rehab or skilled nursing, not both. We're going to choose a pathway for rehab of either rehab or skilled nursing. We're going to complete discharge documentation early on the day of discharge because we want to get our patients over early and settled. No one likes to be admitted to rehab at 9 or 10 o'clock at night and then have to be up for a shower and a bath with their therapist at 7:45 the next morning. So we really do like to get them over early. That makes sure that our physicians are able to thoroughly assess them, our nurses are able to get them settled in, and they can have a good night's rest before they begin their 3 hours of therapy the next day. And for charity patients, if you can involve your financial counselors early, that will also help the process. So that way when I contact the business office, they can get back to me a little faster about those decisions. All right, when you discharge a patient to inpatient rehab, it is an actual discharge, not a transfer, even though we share a hospital. We need a discharge summary. We need orders to discharge to rehab, not transfer to rehab, and we'll need a completed med rec. All right, let's have a little talk about inpatient rehab versus skilled nursing facility. And just as a background, I've spent 10 plus years in skilled nursing and about the same in inpatient rehab. For IRF, for inpatient rehab, patients need to demonstrate that they need close medical supervision by a physician with specialized training. So we have physical medicine and rehab doctors on our floor who are coordinating care. They see their patients every day, and they assess their patients every day. So we need to demonstrate that medical necessity. That's why we need to have that piece. For skilled nursing facilities, physicians come once or twice a week, and in some places they come more than once, and they don't have to have that PM&R piece to their training. For inpatient rehab, we get 24-hour nursing care. It's not required at skilled nursing. Multidisciplinary team of physicians, nurses, case managers, and therapists, again, not required. In an inpatient rehab, 3 hours is a must. And PT, OT, and speech are optional in a skilled nursing facility. If a patient needs nursing care but does not need the rehab portion, then they would seek care in a skilled nursing facility. In rehab, we're going to give them 90 minutes of physical therapy and occupational therapy daily. These come in 45-minute sessions at a time so that we can build in some rest breaks, but it is, there's no compromise. There are 90 minutes each day of PT and OT. In a skilled nursing facility, they can start as low as 15 to 20 minutes and then build up to around the 75 minutes to an hour and a half time period. Now, this is really good to keep in mind for some of your lower level patients who are having a really difficult time tolerating a full session of therapy. Let's get them into skilled nursing where they can get some therapy at their level so that we're not hurting them, we're helping them, and allow that skilled nursing facility therapy team to build on those minutes. And I can guarantee you, again, as having worked in a skilled nursing facility, they get reimbursed by how much time they're spending with their patients. And so it behooves them to increase the patient's therapy time as quickly as possible. And so they can build that tolerance up there at the skilled nursing facility. Speech therapy is optional in both places. Length of stay for inpatient rehab, we've gone over that, is based on a diagnosis and the level of impairment. There is no guaranteed length of stay in inpatient rehab. Whereas skilled nursing facilities, you typically get a 21-day stay with an option to extend up to 100 days. Now on that why they say 21 days, that's when the copay begins to kick in. And so most people like to get out of the skilled nursing facility before they start having to write checks. If there is some co-insurance, oftentimes they'll pick up the copay. But you see that once you finish inpatient rehab, you gotta go home. Once you finish therapy at a skilled nursing facility, if your family is not ready to take care of you or unable to take care of you, then you can stay a little bit longer at a skilled nursing facility. It does help with continuity of care because then you have the same staff and the same therapists who are caring for that patient during their entire rehab experience. IRF rehab is always a planned discharge back to the community, whereas skilled nursing does have the option to transition to long-term care. And here is where, again, when families say to us, let's do rehab and see where that gets us, where I understand their heart. They want their family member to get as much therapy and get as good as they can as possible. If they are, let's say, a working full-time family and no one is willing or able to quit work and stay home with their loved one, if this patient has lived by themselves and will refuse to move in with any of their children, then we're looking at they likely are going to need long-term care. As I'm reviewing documents, if a physician documents this patient will likely need long-term care because of the severity of their impairments, that is obviously going to be a red flag for us because even with intensive inpatient rehab, the burden of their care is going to be more than any family would be able to take care of. All right, again, I can't reiterate this enough, if the patient and the family plan for SNF placement in patient rehab is not indicated, patients and families must choose a path for rehab, either inpatient or skilled nursing, not both. And with an exception, if someone finishes skilled nursing facility rehab, their 21-day stay, and they're doing great, but they're not quite ready to go home, we can bring them to inpatient rehab to finish their rehab course. Now, this is particularly beneficial for people who maybe are bilateral non-weight bearing. They go to the skilled nursing facility to receive the nursing care and some conditioning and some exercise there at the skilled nursing facility. Once they're able to then bear weight into their, let's say, their legs, let's get them into rehab and push the accelerator on their rehab process by giving them that 3 hours of therapy a day. Inpatient rehab for a week. After that, oftentimes we can get people home with just the assistance of their family. Another example would be someone who's had a devastating stroke, a really bad stroke, and they are having a hard time tolerating a full 3 hours of therapy. Send them to the skilled nursing facility, with the intention of hopefully coming to inpatient rehab. Let that skilled nursing facility team of PTs, OTs, and speech therapists build that patient's strength and endurance up, and then at the end of that 21-day stay, bring them back to inpatient rehab for a more intensive rehab stay. And there we'll take on that 3 hours and we'll prepare that patient and the family to go home. All right, and why is Medicare so strict? Why are insurance companies so quick to say a patient does not meet? And the answer's in the numbers. You can see that joint replacements, typically in a skilled nursing rehab scenario, would be $6,000, whereas in inpatient rehab, $17,000. So when you see a single joint replacement and the insurance company says no, or we say no, it is, the numbers don't lie there. It's a lot cheaper to provide care to skilled nursing facility. And again, it's because there's a little less therapy, a little less intensive medical supervision. Same with a hip fracture or strokes. You can see the difference is pretty big between the two numbers. That being said, if you feel that your patient needs inpatient rehab and you don't get the answer that you like, I'm always willing to talk about it with you. If you want to call the office, we'll be glad to talk through it. And it might be that there are some things that can happen on the acute care side that would help the patient to qualify for inpatient rehab, to be more appropriate for inpatient rehab. All right, does anyone have any questions? All right, well, I'm available afterwards if needed. Thank you guys so much.